There's something that a significant number of people experience and almost no one talks about. Not with their friends, not with their partners, and often not even with their doctors. It is pain during sex. Real, recurring, sometimes debilitating physical pain that happens in one of the most intimate areas of human experience. And because it lives at the intersection of the body, the mind, and one of the most private parts of a person's life, it tends to get swallowed in silence for months, sometimes years, sometimes indefinitely. If you are watching this, you may already know exactly what that silence feels like. This video is going to break it open, not with judgment, not with discomfort, but with the kind of honest, medically grounded, humanly respectful conversation that everyone who has experienced sexual pain deserved to have a long time ago. We're going to talk about what causes pain during sex, what your body may actually be signaling, and perhaps most importantly, how to finally have a real conversation with your doctor about it. Because that conversation, the one that so many people put off for so long, is often the thing that changes everything. Stay with me through this entire video, because the section at the end on talking to your doctor is something I am particularly passionate about, and it contains specific language and strategies that will make a real difference when you walk into that appointment. But let us start at the beginning. Let us start with why this problem is so widespread and so widely ignored at the same time. Pain during sex, medically referred to as dyspareunia, is far more common than most people realize. Research suggests that somewhere between 10 and 20% of women experience it at some point in their lives. And while it is less discussed in men, it affects them as well. It can present as pain at the point of initial penetration, deep internal pain during intercourse, burning sensations, pressure, cramping, or pain that persists for hours after sexual activity has ended. And yet, the vast majority of people who experience it do not seek medical help. Studies consistently show that most people wait months or even years before bringing sexual pain up with a healthcare provider. Many never bring it up at all. Why? Because of shame, because of the assumption that something is wrong with them personally rather than medically, because they have been told directly or implicitly that pain during sex is something to push through, to manage, to accept as part of the experience, because they have brought it up before and been dismissed with vague reassurances that it is probably fine, because the idea of saying those specific words out loud to a doctor in a clinical setting feels overwhelming. All of those reasons are understandable. None of them are acceptable as reasons to stay in pain. Sexual pain is a symptom. Like any other symptom in your body, it is information. It is your body communicating that something needs attention. Ignoring it does not make it better. It often makes it worse. And in some cases, it allows an underlying condition that is absolutely treatable to progress unchecked for years, while the person experiencing it silently adapts their life around pain that they never needed to live with. You do not have to live with it, but you have to be willing to get the help that is available to you. Let us start with the physical causes, because there are more of them than most people realize, and understanding them is the first step toward knowing what conversation to have. The most frequently identified physical cause of pain during sex is insufficient lubrication. This sounds simple, and in some cases it is. But it is worth understanding that inadequate natural lubrication is not always a sign of insufficient arousal or emotional disconnection. It can be a direct physiological result of hormonal changes, certain medications, health conditions, and factors that have nothing to do with how attracted you are to your partner or how mentally engaged you are. Estrogen plays a central role in maintaining vaginal tissue health, elasticity, and natural lubrication. When estrogen levels drop, which happens during perimenopause, menopause, postpartum recovery, while breastfeeding, or as a side effect of certain hormonal contraceptives and other medications, the vaginal tissue can become thinner, drier, and more sensitive to friction. This is a medical reality, not a personal failing, and it is one of the most treatable causes of sexual pain when properly identified. Vaginismus is another significant cause, and one that is still poorly understood by many general practitioners. Vaginismus is a condition in which the muscles surrounding the vaginal opening involuntarily contract when penetration is attempted. The contraction is not voluntary or conscious. The person is not choosing to tighten. The body does it automatically. The result is that penetration becomes painful, sometimes extremely so or even impossible. Vaginismus exists on a spectrum. For some people it is situational, meaning it happens in specific contexts but not others. For others it is more generalized. It can develop after a traumatic sexual experience, after childbirth, after a painful gynecological procedure, or for reasons that are not always clearly identifiable. The important thing to know is that vaginismus responds very well to treatment when correctly diagnosed. Pelvic floor physical therapy, in particular, has a strong evidence base for this condition. Endometriosis is a condition in which tissue similar to the lining of the uterus grows outside of it, often on the ovaries, fallopian tubes, or other pelvic structures. Pain during sex, particularly deep internal pain, is one of the hallmark symptoms of endometriosis. It is also one of the most underdiagnosed conditions in women's health. The average time from onset of symptoms to diagnosis is still alarmingly long in many parts of the world, in part because painful periods and painful sex have historically been minimized or normalized in ways that are genuinely medically harmful. If you experience deep pelvic pain during sex, particularly pain that feels worse at certain times of your cycle, please bring endometriosis up specifically with your doctor. Do not wait for them to suggest it. Name it. Pelvic inflammatory disease, commonly referred to as PID, is an infection of the female reproductive organs that can cause significant pelvic pain and pain during intercourse. It often develops as a complication of a sexually transmitted infection, though not always. It requires antibiotic treatment, and when left untreated, it can cause serious complications including damage to the fallopian tubes and effects on fertility. Vulvodynia is chronic pain in the vulvar region without an identifiable cause, such as infection or skin disease. It can present as burning, stinging, irritation, or rawness, and can make sexual activity extremely painful. Like vaginismus, it is underdiagnosed and undertreated, partly because it is invisible from the outside and partly because it falls into that frustrating medical category where the pain is real and significant, but standard tests come back without a clear explanation. Skin conditions including lichen sclerosis and contact dermatitis can cause significant pain, itching, and sensitivity in the genital area that makes sexual activity uncomfortable or painful. These are often not the first thing considered and sometimes require a dermatologist or specialist to properly identify and treat. For men, pain during sex can result from conditions including phimosis, which is tightness of the foreskin that causes pain during erection or intercourse, prostatitis, which is inflammation of the prostate that can cause deep pelvic pain and discomfort during or after ejaculation, Peyronie's disease, which involves the development of scar tissue inside the penis causing painful erections and curved, painful intercourse, as well as infections and certain skin conditions affecting the genital area. The important thread running through all of these conditions is that they are medical. They have names, they have mechanisms, and most of them have treatments, but none of them can be treated if they are never diagnosed. And they cannot be diagnosed if the person experiencing them does not bring them to a healthcare provider. Now let us talk about the hormonal and reproductive causes in more depth, because this is an area where the connection between overall health and sexual health becomes particularly clear and particularly important. Hormonal fluctuations affect sexual health in ways that are still not as widely discussed as they should be. Beyond the menopause and perimenopause connections already mentioned, other hormonal shifts can significantly impact sexual comfort. Thyroid dysfunction, for example, can affect lubrication, libido, and overall tissue health in ways that directly influence sexual experience. Polycystic ovary syndrome, known as POS, involves hormonal imbalances that can affect sexual function and comfort in various ways. Certain antidepressants, antihistamines, blood pressure medications, and other commonly prescribed drugs can all reduce natural lubrication or affect sexual response in ways that contribute to discomfort. This is why a thorough medical history is so important when you raise sexual pain with your doctor. not just what hurts and when, but everything you are taking, every health condition you are managing, every significant hormonal event in your life. All of it is potentially relevant. The postpartum period deserves particular attention here. Following childbirth, especially vaginal delivery, the body undergoes significant changes. Estrogen levels drop sharply, particularly in women who are breastfeeding. Healing tissue can be sensitive for months. The pelvic floor, which has been under extraordinary stress, often needs time and sometimes specific rehabilitation to return to full function. Pain during sex in the postpartum period is extremely common and extremely underdressed. Many people are told they can resume sexual activity after a standard clearance appointment with no acknowledgement of the physical reality they are likely still navigating. If you are postpartum and experiencing sexual pain, you are not alone, and you deserve specific care, not just a green light and silence. Now, let us turn to the psychological dimension of sexual pain, because this is the area that is most frequently misunderstood and most frequently used inappropriately to dismiss people's physical experience. The relationship between psychology and physical pain is real, bidirectional, and complex. Anxiety, particularly performance anxiety or anxiety around sexual experiences, creates real physiological effects. When the nervous system is in a state of anxiety, the body shifts into a protective mode. Muscle tension increases, natural lubrication decreases, sensitivity to sensation changes. The body becomes less conducive to comfortable, relaxed physical intimacy. This is not imaginary. These are measurable physical effects of a psychological state. Trauma history, including but not limited to sexual trauma, can have profound effects on how the body responds to sexual activity. The nervous system stores traumatic experience in ways that can produce physical pain, tension, and protective reactions in the body long after the original event. This is well documented in trauma research, and it means that for some people, sexual pain has psychological roots that require psychological care, specifically trauma-informed therapy, in addition to, or sometimes instead of, purely physical treatment. The critical thing to understand here is that psychological causes of physical pain do not make the pain less real. They do not make the person less deserving of care. They do not mean the person is broken or that the problem is unsolvable. They simply mean that the treatment pathway runs through the nervous system and the mind as well as the body. It is also important to name the cycle that develops when sexual pain goes unaddressed. Pain during sex creates anticipatory anxiety. Anticipatory anxiety creates muscle tension. Muscle tension creates more pain. The pain reinforces the anxiety. The anxiety deepens the tension. Over time, what may have started as a purely physical issue develops a psychological layer, and vice versa. Breaking that cycle requires addressing both dimensions. Relationship dynamics also play a role. Feeling emotionally unsafe with a partner, unresolved relationship conflict, feeling pressured or unheard within a sexual relationship. These things have genuine physical effects on sexual experience. A body that does not feel safe does not respond the way a body that feels fully safe does. This is not a moral judgment. It is physiology. There is one more dimension to this that deserves direct acknowledgement. Cultural and religious messages about sexuality can create deep-seated shame, guilt, and anxiety that produce real physical consequences. Many people carry internal conflict about sexual activity that their bodies express through pain, tension, and discomfort. This too deserves compassionate, skilled care rather than dismissal or judgment. Now, we need to talk about when sexual pain is a warning sign for something that needs more immediate attention. Most sexual pain is not a medical emergency, but some is a signal that requires prompt evaluation. You should see a doctor relatively quickly if sexual pain is accompanied by unusual discharge that may indicate infection, if you develop fever or chills alongside pelvic pain, if you experience sudden severe pelvic pain rather than chronic discomfort, if you notice unexpected bleeding related to sexual activity, if pelvic pain is persistent and worsening even outside of sexual contexts, or if you have any reason to believe you may have been exposed to a sexually transmitted infection. These situations call for prompt medical attention rather than the watch and wait approach that might be appropriate for milder, more stable discomfort. For chronic sexual pain without acute red flags, the timeline for seeking care is still sooner rather than later. There is no medical benefit to waiting. There is significant benefit physically and psychologically to getting answers and beginning appropriate treatment as early as possible. Now, let us get to the section I told you about at the beginning, the one that I think is the most practically important part of this entire video: how to actually talk to your doctor about sexual pain. Because knowing that you should talk to your doctor and being able to actually do it are two entirely different things. And the gap between those two things keeps millions of people in unnecessary pain. Here is everything you need to know to walk into that appointment prepared. First, choose the right setting. If your primary care physician or general practitioner is someone you trust and feel comfortable with, start there. If you have a gynecologist or urologist you see regularly, that may be an even better starting point. If you do not feel comfortable with your current provider for this conversation, it is completely appropriate to seek a provider who specializes in sexual health, pelvic floor health, or women's health specifically. You deserve a doctor who will engage with this topic seriously and without judgment. If your current doctor is not that person, that is important information. Second, plan what you are going to say before you get there. The anticipation of this conversation often feels much worse than the conversation itself, but having specific language prepared makes it significantly easier. You do not have to have a perfect medical explanation of what is happening. You just need to open the door. Here is language that works. You might say something like, "I have been experiencing pain during sex, and I would like to talk about it. I have been dealing with this for a while and I have not brought it up before, but I think it is important that we discuss it. I am having discomfort during intercourse, and I am not sure what is causing it. I would like your help figuring that out." Those sentences are enough. You do not need more than that to start. The doctor's job is to ask the follow-up questions. Third, be as specific as you can about what you are experiencing. Where exactly does the pain occur? Is it at the point of initial penetration, deep internally, externally, or all of the above? How would you describe the sensation? Burning, sharp, aching, pressure, or something else? How long has it been happening? Does it occur every time or only sometimes? And if sometimes, do you notice any pattern to when it happens or does not happen? Does the pain occur only during sex, or do you also experience related discomfort at other times, such as during gynecological exams, using tampons, sitting for long periods, or during menstruation? Does the pain persist after sex, and if so, for how long? The more specifically you can describe your experience, the more useful information your doctor has to work with. Fourth, mention everything that might be relevant even if it does not seem connected. All of your current medications, any recent hormonal changes including starting or stopping contraception, recent pregnancies or deliveries, any history of conditions that have been mentioned in this video, such as endometriosis, PCOS, or thyroid issues, any history of pelvic surgeries or procedures, any recent infections you're aware of, and yes, your stress levels and mental health, because as we have discussed, these are medically relevant and a good doctor will want to know. Fifth, ask direct questions and do not leave until you have answers you understand. Ask your doctor what they think may be causing your pain. Ask what diagnostic steps they want to take and why. Ask what treatment options are available if a cause is identified. Ask what you should do if the pain continues or worsens before your next appointment. Ask whether they would recommend any specialist referrals, such as a pelvic floor physical therapist, a gynecologist who specializes in sexual pain disorders, or a therapist who works with sexual health issues. You are not being demanding by asking these questions. You are advocating for appropriate care of a real health concern. That is exactly what you are supposed to do. Sixth, and this is important, if your doctor dismisses your concern without adequate investigation, you are allowed to push back. You are allowed to say, I understand that this may not seem urgent, but this has been affecting my quality of life, and I would like it taken seriously. You are allowed to ask for a referral to a specialist. You are allowed to seek a second opinion. A dismissive response to a genuine, ongoing health concern is not the end of the road. It is a signal to keep looking until you find a provider who will properly address what you are experiencing. The medical community has historically done a poor job of taking sexual pain seriously, particularly in women. Research has consistently shown that women's pain is more likely to be dismissed, minimized, and attributed to psychological causes without adequate investigation compared to men's pain. Knowing this going in is not meant to discourage you. It is meant to empower you to advocate persistently for the care you deserve. Now, let us talk about the treatment options that are actually available, because the range of effective interventions for sexual pain is broader than most people realize. Pelvic floor physical therapy is one of the most effective and most underutilized treatments for sexual pain. A pelvic floor physical therapist is a specialist who works with the muscles, connective tissue, and nerves of the pelvic region. For conditions like vaginismus, dyspareunia related to pelvic floor tension, postpartum pelvic floor dysfunction, and chronic pelvic pain, pelvic floor PT has strong evidence behind it and has helped enormous numbers of people regain comfortable, pain-free sexual function. If your doctor does not mention this option, ask about it directly. Hormonal treatments can address sexual pain that results from low estrogen or other hormonal imbalances. These may include localized vaginal estrogen therapy, systemic hormone therapy, adjusting contraceptive medications, or treating underlying hormonal conditions like thyroid dysfunction or POS. The specific approach depends entirely on what is driving the hormonal issue and individual health history. High-quality lubricants and vaginal moisturizers are genuinely medically useful tools, not just comfort measures. For pain related to dryness or tissue sensitivity, these can make a significant immediate difference, while other treatments address underlying causes. A healthcare provider can help you identify products that are appropriate for your specific situation. Medical treatment of underlying conditions is obviously essential when a specific condition is identified. Endometriosis, pelvic inflammatory disease, skin conditions, infections, prostatitis, Peyronie's disease, and other identifiable causes all have their own specific treatment pathways that your doctor can guide you through once the underlying cause is established. Psychological and therapeutic support is a legitimate and important part of treatment for many people experiencing sexual pain. Cognitive behavioral therapy adapted for sexual health concerns, trauma-informed therapy, and sex therapy all have evidence supporting their effectiveness for pain that has psychological dimensions, as well as for the anxiety and relationship effects that often develop around chronic sexual pain, regardless of its origin. A therapist who specializes in sexual health or somatic approaches to trauma can be a powerful part of a comprehensive treatment plan. Couples therapy or relationship counseling may also be valuable when sexual pain has created tension, communication breakdown, or emotional distance within a relationship. Both partners are affected when sexual pain is present, and addressing it together with professional support can be deeply helpful. Mindfulness-based approaches, including mindfulness meditation and somatic awareness practices, have emerging evidence for their role in reducing pain sensitivity and interrupting the anxiety-tension pain cycle that often develops around chronic sexual pain. These are not replacements for medical care, but they can be meaningful complements to it. I want to close this video by saying something that I want you to genuinely hear. Sexual pain is not a punishment. It is not a reflection of who you are as a person or as a partner. It is not something you did wrong. It is not something you simply have to live with. It is a health issue. Like any other health issue, it exists, it has causes, and in the vast majority of cases, it responds to appropriate care. The silence around this topic has caused real harm. It has kept people in pain that did not need to be permanent. It has allowed treatable conditions to go unidentified for years. It has created shame where there should be only information and support. And it has made millions of people feel alone in an experience that is actually shared by a significant portion of humanity. You are not alone in this. If you have been carrying this question quietly, the fact that you are watching this video right now means something. It means you are ready to stop accepting pain as inevitable. It means you are ready to get answers. It means you are ready to have the conversation that has been waiting. Make the appointment. Write down your symptoms before you go. Use the language we talked about in this video. Ask the questions you deserve answers to. And if the first doctor does not take you seriously, find one who will. Because the care you need exists. The treatments that work exist. The version of your life where this pain is addressed, understood, and resolved, that exists too. It starts with one conversation. You deserve to have it. Thank you for trusting me with this topic today. If this video helped you feel less alone, more informed, or more prepared to seek the care you deserve, please share it with someone who needs it. Subscribe for more health content that treats you like the intelligent, deserving person you are. And drop a comment below telling me what you found most helpful, because this community matters and your voice in it does too.